Hello, I'm Antoni Chan. I'm a consultant rheumatologist from London, United Kingdom, reporting here at ACR 21 for the Room Now site. There have been some interesting abstracts at the ACR 21, and today I want to focus on the question of predicting flares. I had shared with you in a previous video how dose tapering can be successful with biologics in spondyloarthritis. However, it's really important to understand what the risks of having a flare-up should a patient dose taper. There are two important abstracts that I'd like to share with you. First is 0929. This is from the same Danish group who had also looked at the efficacy and ability to dose taper. In this study, they looked at the factors that cause patients to flare up. And these were axial spondyloarthritis patients. And what they did is they followed the patients up for a period of 48 weeks. And in this time, they either had a dose reduction to 2/3, a half, a third, or down to 0. It was clear that in this time that most of these patients, there were 109 patients in the study, 106 of them had a flare-up due to the dose reduction. And these were either clinical flare-ups or flare-up by either imaging or BAF scores. And the clinical remission scores were that they had to reach a physician global assessment of less than 40 and BASTI of less than 40 prior to the dose taper. In this study, they showed that the most important predicting factor for future flare-ups when patients are dose tapered is actually the physician global assessment. In other words, if the clinician feels that this patient has a high activity score based on the physician global assessment, these patients are probably more likely to have flare-up during the dose taper program. Another factor which came out in the higher dose reductions in the half group was also increasing age. So this tells us that clinically, we have to be assessing our patients carefully, and we feel that their disease activity is significant from our physician assessment, then we'll probably be more cautious about dose tapering these patients. There was also a very interesting abstract, 0916, which looked at the use of certolizumab in patients with axial spondyloarthritis. After a period of 48 weeks, when these patients achieved clinical remission, they were then put into 3 groups. They either received the same dose of certolizumab, the reduced dose, or they received just placebo. And they were followed up for another 48 weeks. And although a lot of these patients did not achieve clinical flare-up, there was a trend towards an increase in their BAF scores, the BASTI, the STAS, the CRP, and also the fecal calprotectin when the patients were in the placebo group, as in they're not receiving any active treatment compared to those who then received the full dose of certolizumab or the reduced dose of certolizumab. Now, this is going to be interesting and certainly need a longer-term follow-up, that patients who do not receive any treatment are probably tending to have increased activity, although they may not report a full clinical flare-up. So I think these two abstracts tell us that we probably should be keeping our patients on some dose of biologics, TNF alpha inhibitors, dose reduction, dose tapering, but not completely stopping these drugs, as we do know that the condition often does come back with a flare-up or relapse upon stopping the drug completely. So I think these two studies should add to our understanding of how to do dose tapering, how to predict flares, and how to manage our patients in the long term. I'm Antoni Chan, reporting from ACR 21 for Room Now.